Welcome, future doctors, to another Uber School production. I'm Pete, and today we're diving deep into the world of endocrine pathology for your USMLE Step 1 prep. Joining me is my co-host, the man who once arm-wrestled a grizzly bear just to test his cortisol levels.
Oh, stop it, Pete. I'm Gary, but you can call me Crash. And let me tell you, that bear had nothing on the stress of med school exams. Speaking of stress, let's kick things off with the granddaddy of all endocrine disorders, diabetes mellitus. Pete, what's your take on this sweet, sweet disease?
Well, Crash, diabetes mellitus is like that annoying relative who shows up uninvited and wreaks havoc on your pancreas. We've got three main types to cover: type 1, type 2, and gestational diabetes. Let's start with type 1, shall we?
Absolutely, Pete. Type 1 diabetes is like your pancreas going on a permanent strike. The beta cells get taken out by overzealous T cells, leaving you high and dry without insulin. It's an autoimmune party where insulin production is definitely not invited.
That's right, Crash. And when those beta cells go down, it's like someone turned off the insulin faucet. Patients often present with the 3 Ps: polyuria, polydipsia, and unexplained weight loss. It's like their body is a leaky bucket, constantly losing water and nutrients.
Exactly, Pete. And don't forget, diagnosis isn't just about feeling thirsty and peeing a lot. We've got some hard numbers to remember. A fasting plasma glucose of 126 milligrams per deciliter or higher, or an HbA1c of 6.5% or above, and you've got yourself a diabetes diagnosis.
Good point, Crash. Now, let's talk complications. We've got microvascular issues like retinopathy, nephropathy, and neuropathy. Then there are the macrovascular problems like cardiovascular disease and stroke. It's like diabetes is playing a game of how many organs can I mess with?
You've got that right, Pete. Now here's a question for our listeners. Which of the following is not a typical symptom of newly diagnosed type 1 diabetes? A, polyuria, B, polydipsia, C, weight gain, or D, fatigue?
That's a great question, Crash. Take a moment to think about it, listeners. We'll come back to the answer in a bit. Now, let's move on to type 2 diabetes, the sneaky cousin of type 1.
Ah, yes, type 2 diabetes, the lifestyle disease that's taking the world by storm. Unlike type 1, your pancreas isn't on strike, it's just getting lazy and inefficient. We're talking insulin resistance here, folks.
Exactly, Crash. It's like your cells have decided to ignore insulin's knocking, no matter how loud it gets. Risk factors include obesity, sedentary lifestyle, and genetic predisposition. It's like your body is a nightclub, and insulin is the bouncer who's lost all authority.
Nice analogy, Pete. And here's where it gets tricky. The diagnostic criteria are the same as type 1, but the onset is often more insidious. Patients might not even know they have it until complications start showing up.
That's right, Crash. Management is a bit different too. We start with lifestyle modifications, then move on to oral hypoglycemics, and eventually insulin therapy if needed. It's like a diabetes treatment escalator.
Speaking of escalators, did I ever tell you about the time Marcus Cooper rode an escalator for 72 hours straight just to prove a point about endurance? The man's glucose levels were through the roof by the end of it.
Crash, I swear your Marcus Cooper stories get wilder every time. But let's get back on track. We've still got gestational diabetes to cover.
Right you are, Pete. Gestational diabetes is like the unexpected guest at the pregnancy party. It typically shows up between 24 to 28 weeks of pregnancy, which is when we do the screening.
And how do we diagnose it, Crash?
Great question, Pete. We use the oral glucose tolerance test. It's like a sweet challenge for the pregnant body. If it fails this sugar test, we've got gestational diabetes on our hands.
Exactly. And the complications can be serious. We're talking macrosomia, that's a big baby, neonatal hypoglycemia, and an increased risk of type 2 diabetes for the mother later in life. It's like a preview of potential metabolic issues to come.
Now, let's circle back to our question from earlier. Remember we asked, which is not a typical symptom of newly diagnosed type 1 diabetes? The answer is C, weight gain. Type 1 diabetics typically experience weight loss, not gain, due to the lack of insulin and the body's inability to use glucose properly.
Good recap, Crash. Now let's move on to another endocrine hotspot, the thyroid gland. This butterfly-shaped gland in your neck is like the thermostat of your body, regulating metabolism and energy use.
That's right, Pete. And just like a thermostat, it can go haywire in two directions, too hot or too cold. Let's start with hyperthyroidism, shall we?
Absolutely. Hyperthyroidism is like your body's engine revving too high. The most common cause is Graves' disease, where autoantibodies start stimulating the TSH receptor like there's no tomorrow.
And the symptoms are just what you'd expect from an overactive metabolism: weight loss despite increased appetite, heat intolerance, and don't forget about those bulging eyes, or exophthalmos. It's like the thyroid is trying to push the eyes right out of the skull.
Graphic but accurate, crash. Diagnosis is confirmed with low TSH and elevated T3 and T4. But remember, Graves isn't the only hypothyroid game in town. We've also got toxic multinodular goiter and toxic adenoma to consider.
Right you are, Pete. Now let's cool things down and talk about hypothyroidism. If hyperthyroidism is the gas pedal, hypothyroidism is definitely the brakes.
Exactly, Crash. In iodine-sufficient areas, the most common cause is Hashimoto's thyroiditis. It's like the immune system decided the thyroid was an unwelcome guest and started tearing it down.
And the symptoms are pretty much the opposite of hyperthyroidism, right? We're talking fatigue, weight gain, and cold intolerance. It's like the body's dimmer switch got turned way down.
Spot on, Crash. And don't forget about iodine deficiency. It's still a significant cause worldwide, leading to goiter formation. It's like trying to make thyroid hormone without the key ingredient.
Now, Pete, let's talk about something a bit more sinister: thyroid neoplasms. These are the troublemakers of the thyroid world.
Right, you are, Crash. The most common type is papillary carcinoma. It's like the overachiever of thyroid cancers, most common, and with the best prognosis. It likes to spread lymphatically and often has those characteristic Samoma bodies on histology.
Don't forget about follicular carcinoma, Pete. This sneaky cancer prefers to spread hematogenously. And then there's medullary thyroid carcinoma, the black sheep of thyroid cancers.
Ah, yes, medullary thyroid carcinoma, the one that's not derived from follicular cells, but from C cells. It's associated with MEN 2A and 2B syndromes and produces calcitonin. It's like the thyroid's way of saying, I can make hormones too.
Great overview, Pete. Now here's another question for our listeners. Which of the following is not a typical feature of Graves' disease? A, exophthalmos, B, weight gain, C, tachycardia, or D, heat intolerance?
Excellent question, Crash. We'll come back to that one. Now, let's move on to the adrenal glands. These little hats sitting on top of our kidneys pack quite a punch when it comes to hormone production.
You got that right, Pete. Let's start with Cushing's syndrome, the disorder that makes you look like you've been hitting the steroids a bit too hard.
Cushing's syndrome is like your body decided to go all in on cortisol production. The most common cause is actually iatrogenic, too many exogenous steroids. But don't forget about Cushing's disease, where a pituitary adenoma is the culprit, or those sneaky adrenal tumors.
And the clinical features are pretty distinctive, aren't they? We're talking central obesity, moon facies, buffalo hump, and those purple striae. It's like the body is being reshaped by all that cortisol.
Exactly, Crash. And diagnosis isn't always straightforward. We've got the 24-hour urinary-free cortisol test and the overnight dexamethasone suppression test. It's like playing hormonal detective.
Now let's flip the script and talk about Addison's disease, or primary adrenal insufficiency. If Cushing's is too much cortisol, Addison's is not enough.
Right you are, Crash. Addison's can be caused by autoimmune adrenalitis, tuberculosis, or even metastatic cancer. It's like someone pulled the plug on your adrenal glands.
And the presentation is pretty much the opposite of Cushing's, isn't it? We're talking fatigue, weight loss, and hyperpigmentation. It's like the body is running on fumes.
Exactly. Diagnosis is confirmed with the ACTH stimulation test, and management involves lifelong glucocorticoid and mineralocorticoid replacement. It's like giving the body back the hormones it can't make on its own.
Now, Pete, let's talk about everyone's favorite adrenal tumor, pheochromocytoma. It's the drama queen of the endocrine world.
Ah, yes, the tumor that likes to keep you on your toes, literally. Remember the classic triad, headache, sweating, and tachycardia? It's like your body is constantly preparing for a fight or flight response.
And don't forget its associations, MEN 2A and 2B, von Hippel-Lindau disease, and neurofibromatosis type 1. It's like the tumor has its own little club of genetic disorders.
Right, you are, Crash. Diagnosis involves measuring plasma or urinary metnephrines, and treatment is surgical resection. But remember, alpha blockade before surgery is crucial. It's like disarming a bomb before you try to remove it.
Great analogy, Pete. Now let's circle back to our thyroid question. Remember, we asked which is not a typical feature of Graves' disease. The answer is B, weight gain. Despite increased appetite, Graves' disease typically causes weight loss due to the hypermetabolic state.
Excellent point, Crash. Now, let's move on to the master gland, the pituitary. This pea-sized powerhouse controls most of the other endocrine glands in the body.
Right you are, Pete. Let's start with the most common functioning pituitary tumor, prolactinoma. It's like the pituitary decided to go into the milk production business.
Good one, Crash. Prolactinomas cause galactorrhea and amenorrhea in women, and decreased libido and impotence in men. It's like the body is preparing for breastfeeding, whether you like it or not.
And diagnosis is pretty straightforward: elevated serum prolactin levels and imaging studies. Treatment typically involves dopamine agonists like bromocriptine or cabergoline. It's like telling the pituitary to calm down and stop making so much milk.
Now, let's talk about growth hormone-secreting adenomas, the cause of acromegaly in adults. It's like your body decided to have a second growth spurt, but only in certain areas.
Right, Pete. We're talking enlargement of hands, feet, and facial features. It's like your body is trying to become a caricature of itself. And don't forget the complications: cardiovascular disease, sleep apnea, and arthropathy.
Good point, Crash. Diagnosis involves elevated IGF-1 levels and failure to suppress GH after a glucose load. Treatment options include surgery, radiation therapy, and medical treatment with somatostatin analogs. It's like trying to put the brakes on runaway growth.
Now, let's talk about when the pituitary decides to go on strike, hypopituitarism. It's like the conductor of the endocrine orchestra suddenly stopped showing up to work.
Nice analogy, Crash. Hypopituitarism can be caused by tumors, infarction, like in Sheehan syndrome, or infiltrative diseases. The clinical manifestations depend on which hormones are deficient.
And remember the order of hormone loss, Pete? It's like the pituitary is playing a game of last one standing.
Right you are, Crash. The order typically goes GH, FSH/LH, TSH, and finally ACTH. It's like the pituitary is deciding which hormones it can live without, one by one.
And treatment involves hormone replacement therapy. It's like stepping in to do the pituitary's job when it can't do it anymore.
Exactly. Now let's move on to our last topic, parathyroid disorders. These tiny glands have a big job when it comes to calcium homeostasis.
Right you are, Pete. Let's start with primary hyperparathyroidism. It's like one of your parathyroid glands decided to become an overachiever.
Good one, Crash. Primary hyperparathyroidism is most commonly caused by a single parathyroid adenoma. It's like one gland decided to go rogue and start pumping out PTH like there's no tomorrow.
And the clinical manifestations are classic, aren't they? Remember the mnemonic: bones, stones, abdominal groans, and psychic moans. It's like the excess calcium is causing trouble all over the body.
Exactly, Crash. And don't forget the key lab findings: hypercalcemia with inappropriately normal or elevated PTH. It's like the parathyroid gland didn't get the memo that calcium levels are already high.
Treatment is usually surgical removal of the affected gland or glands. It's like firing the overenthusiastic employee who's causing all the trouble.
Now, let's talk about secondary hyperparathyroidism. This is when the parathyroid glands are actually responding appropriately to a problem elsewhere in the body.
Right, Pete. Common causes are chronic kidney disease and vitamin D deficiency. It's like the parathyroid glands are trying to compensate for low calcium levels by pumping out more PTH.
Exactly, Crash. And management focuses on treating the underlying cause. We might use vitamin D supplementation or calcimimetics. It's like trying to fix the root of the problem rather than just treating the symptoms.
Now let's flip the script and talk about hypoparathyroidism. It's like the parathyroid glands decided to take an unscheduled vacation.
Good analogy, Kraus. Hypoparathyroidism is most commonly post-surgical, but it can also be autoimmune or genetic. The clinical presentation includes hypocalcemia symptoms like tetany and seizures. It's like the body is starving for calcium.
And treatment involves calcium and vitamin D supplementation, right? It's like we're stepping in to do the parathyroid gland's job for them.
Exactly, Crash. Now let's wrap up with one final USMLE style question. A 45-year-old woman presents with fatigue, weight gain, and cold intolerance. Lab tests show elevated TSH and low T4. What is the most likely diagnosis?
Great question, Pete. Is it A, Graves' disease, B, Hashimoto's thyroiditis, C, thyroid storm, or D, subacute thyroiditis?
Take a moment to think about it, listeners. The correct answer is B, Hashimoto's thyroiditis. The symptoms of fatigue, weight gain, and cold intolerance, along with elevated TSH and low T4, are classic for hyperthyroidism, and Hashimoto's is the most common cause in iodine-sufficient areas.
Excellent explanation, Pete. Well, folks, that wraps up our whirlwind tour of endocrine pathology. Remember, understanding these concepts is crucial for acing your USMLE Step 1.
Absolutely, Crash. And always keep in mind the clinical presentations, diagnostic criteria, and treatment options for these disorders. They're not just facts to memorize, but real conditions that affect real patients.
Couldn't have said it better myself, Pete. And remember, future doctors, this has been an Uber School production. We're here to help you not just pass your exams, but become the best physicians you can be.
That's right, Crash. Until next time, keep studying, stay curious, and don't forget to take care of your own endocrine system along the way.